Okay, Natalie, so I'll get started. Just give me a couple of minutes, okay, just to introduce you to the rest of the group who doesn't know you, obviously. So good morning, everyone. Welcome to Renal Grand Rounds DASH Recruitment Seminar. As many of you in the faculty know, that the division is looking for a new clinical educator to start July 1st of next year. And we're very fortunate that one of our second-year fellows, Dr. Natalie Beck, is interested in the position, and she will present today an interview with some of the faculty members in the division. For those of you who do not know Natalie, she did her undergrad at the University of Portland in Oregon. She graduated from med school at OHSU in Oregon. Important to note that she graduated as magna cum laude, and she was an inductee of AOA in the junior class. Then she traveled east toward the Rocky Mountains, where she did her residency here at the University of Colorado. And we were fortunate enough to actually attract Natalie to become one of our renal fellows. And currently she serves as our chief nephrology fellow. Natalie has had the opportunity of having various teaching experiences, including a small group facilitator with the medical school, as well as teaching the nephrology pearls to the hospitalist group. She's been involved in research with Dr. Kendrick in focused research groups, as well as a resident when she was here with the cardiology division. She lists a series of presentations as a resident when she was an internal medicine resident and obviously a fellow, as well as a nice group of publications. So Natalie, thank you for giving grand rounds. Thank you for applying to this position. And we're all looking forward to the day.
Thank you for having me. So today I'm going to talk about obesity and how it pertains to CKD. Can everyone see my screen okay?
Very well, Natalie. Yeah.
Okay. So the objectives that we'll talk about today will define obesity in various ways. We'll describe the direct renal effects that are caused by obesity. We'll review the literature on various renal outcomes with varying weight loss modalities. And we'll understand which weight loss resources exist in each of our hospital systems. So this grand rounds was inspired by a case, a patient that I saw in my clinic at Denver Health. She was a 22-year-old woman with class 3 obesity with a BMI of 69, who was referred to me for macroalbuminuria. Her urine albumin creatinine ratio was 1.8 grams per gram, but after she started on an ACE inhibitor, it reduced to 150 milligrams per gram. Her creatinine was normal with an estimated GFR of 115. She had a negative serologic workup for causes of nephrosis, including not a diabetic with an A1C of 5.6%. Additionally, after starting on the ACE inhibitor, her blood pressure was 124/76. So this prompted me to think of what are the research out there, what's the data on the benefits of weight loss in this woman who has obesity, but doesn't seem to have many of the other comorbidities that go along with it. So the main way that obesity is defined in the literature is by the World Health Organization classification, which I'm sure we're all familiar with overweight being defined as a BMI between 25 to 29.9, and the different classes of obesity being above a BMI of 30. However, it was found that in the Asian Pacific populations, there was an increased risk of comorbidities with a BMI of less than 25, which is the World Health Organization cutoff for overweight. So there are other numbers that are sometimes used in the literature as risk criteria in this population. The problem with using BMI to measure obesity is that it doesn't really capture the body composition, with the important one being central adiposity. So in this cartoon figure here, we can imagine that this person would have a normal BMI, but we can clearly see that they have increased visceral or abdominal fat. And this has been shown to be a strong predictor of mortality, even when you adjust for total body fat, even in a patient of normal BMI. There are other ways of measuring adiposity or weight in general. The CT and DEXA are gold standards for measuring abdominal fat, but we also have skin fold thickness, the waist to hip ratio, the waist circumference, and of course we have the BMI. So looking at things other than BMI to get at the central adiposity, the waist size has been used as well and has been shown to be a predictor of these comorbidities. And it's been shown that waist size for females above 88 centimeters or for males above 102 centimeters are an increased risk of these comorbidities. For the Asian populations, they are lower, females of less than 79 centimeters and males of less than 89 centimeters. And the waist hip ratio of 0.9 for males and 0.8 for females. I could not find a waist hip ratio for Asian populations in the literature. So there was a study that looked at the central body fat distribution and whether this changes renal hemodynamics independent of body mass index. So in this study, they had 315 healthy people, so their BMI was less than 25, the cutoff for overweight, and they used an iothalamate GFR to see that the mean was 109 in this population. When they looked at increasing waist to hip ratio, which gets at central adiposity, this was associated with a lower GFR, a lower effective renal plasma flow, higher filtration fraction, and this was even after adjusting for sex, age, blood pressure, and BMI. So this may be a reason why the underlying increased renal risk is seen with patients with obesity. So what we'll go through are the risk factors. The main ones we know are that all of these indirect effects of obesity, mainly what we call the metabolic syndrome, have effects on our kidneys. So hypertension, diabetes, atherosclerosis, all increase risk of developing CKD. But there are direct effects which have also been shown, independent of those indirect ones, to have effect on the kidney. Both basic science and clinical studies have shown some of these factors. Interestingly, some show that in certain glomerular diseases where obesity isn't really part of the underlying pathophysiology, like PKD and IgA nephropathy, in some of those, patients who also have underlying obesity seem to have acceleration of CKD progression. Although in the IgA population, this wasn't shown in all of the studies that have looked at that. Some of the structural changes that are seen in obesity include fatty infiltration of the kidney parenchyma, hyperfiltration, leading to intraglomerular hypertension, which puts stress on the glomerulus and podocyte damage, leading to obesity-related glomerulopathy, the hallmark of which is proteinuria and FSGS. There's some evidence to support that the hemodynamic changes in obesity exist, and one interesting one was looking at patients who were given ramipril and what happened to their proteinuria. And in particular, the patients who were obese seemed to have a much more significant decrease in their proteinuria than those who were of normal or overweight body habitus. And in this study, with the diagram here, was about 340 patients, 31% of whom were overweight and 15% of whom were obese. And this was looking at their 24-hour proteinuria with more pronounced reduction in the obese patients who got an ACE inhibitor. There are also inflammatory effects that the adipocytes can release factors which have effects on the kidneys. In obesity, we see higher leptin levels. Leptin can bind to receptors in the glomerulus called the OBR A and B receptors, which can lead to increased TGF-beta, leading to increased mesangial extracellular matrix and fibrosis. It also activates the sympathetic nervous system in the hypothalamus and can lead to hypertension in that way, but additionally can directly cause renal sodium retention, another way that it causes hypertension. There's also lower levels of adiponectin in obese patients. This is thought to be an anti-inflammatory mediator, which blocks NF-kappa B and inhibits production of IL-6 and TNF-alpha, and it can promote insulin sensitivity. It also has been shown to have some protective effects on podocyte function. There was one study of adiponectin knockout mice, and they were shown to have albuminuria and foot process fusion. But when they were given exogenous adiponectin, they had normal albumin excretion and improved podocyte morphology. Aside of all of the effects that obesity can have both on the kidney directly and indirectly, it also can cause barriers to giving optimal CKD care. So patients who are overweight or obese can have more challenging vascular access, including issues with healing and with maturation of fistulas. Some have shown more episodes of PD-associated peritonitis. Patients can often have difficulty with mobility and getting transportation to their hemodialysis, which makes adherence more difficult. And access to kidney transplantation is reduced depending on the centers. Many have cutoffs of a BMI of less than 35. There have been some pretty large cohort studies to see if obesity is a risk factor for CKD. One of them is the Kaiser Permanente cohort in California, which was linked with the US Renal Data System. So about 320,000 patients. And they were looking at the risk of ESRD in obese patients compared to normal weight patients. The overweight patients had a hazard ratio of 1.9, class 1 obesity of 3.6, class 2 obesity of 6.1, and class 3 obesity of 7.1 risk of ESRD compared to normal weight. And this was independent of their socioeconomic status, comorbidities, and even lab tests, including proteinuria. Another risk factor abroad, with a large cohort of Israeli adolescents, 1.2 million of them who were examined for military fitness, which was linked to their national ESRD registry, and looked at these patients for a mean of 26 years. Those who were overweight in the 85th to 95th percentile BMI at the time of enrollment had a 3-time higher risk of developing ESRD in this follow-up period. And the obese patients, which was defined as greater than 95th percentile BMI, had a 7-time higher risk of developing ESRD. This was independent of sex or blood pressure. So there was a cohort looking at the incidence of moderately severe CKD. This was in patients in Sweden, age 18 to 74. They had about 930 case and 1,000 control subjects. And they looked at people who had a serum creatinine that was permanently above 3.4 for males or 2.8 for females. And they found that those who had been overweight at age 20 was associated with a 3 times risk for developing CKD by these definitions. This primary outcome was found in about 20% of, got a little lost in my notes there. Those who did not have hypertension or diabetes still had triple the risk for developing CKD. And then finally, we have a prospective cohort looking at the progression of CKD in obese patients. This was a study of about 2,000 patients in Korea in a cohort looking at pre-dialysis patients of any stage of CKD. Obesity was defined as a BMI greater than 25, and that was about 42% of the patients. They looked at whether they had metabolic abnormality, and they had to have 3 or more to qualify of hypertension, hyperglycemia or type 2 diabetes, hypertriglyceridemia or needing lipid-lowering drugs, low HDL, or an increased CRP indicative of inflammation. So about 62% of the people in this cohort qualified for metabolic abnormality, and about half of the patients had diabetes, both in the obese and non-obese cohorts. So these patients were followed for about 3 years, and the primary outcome was looking at either 50% decline in GFR or development of ESRD requiring either dialysis or a transplant. This outcome overall occurred in about 20% of the cohort. Those who were obese had a 1.4-fold increased risk, which was statistically significant. And those with metabolic abnormality had about a 1.4 increased risk, even without obesity. But when they looked at the obese patients themselves and whether or not they had metabolic abnormality, in fact, they showed that people who didn't have metabolic abnormality had almost a double risk of this primary outcome seen by the blue star here. And those with both had about a 1.5-fold increased risk above those who were non-obese, either with metabolic abnormality or without metabolic abnormality. So obesity without a metabolic abnormality almost doubled the risk of CKD progression. Another idea that I came across in the literature is something called the obesity paradox. So the obesity paradox was described by Fleischman in 1999. He looked at a group of dialysis-dependent patients in Mississippi, about 1,350 of them, and looked at one-year mortality or hospitalizations, and showed that in the overweight groups, they actually had less hospitalizations and mortality in that year than the patients who were underweight, which is this top line with the open boxes. The normal weight was here in the middle, and the overweight groups actually seemed to do better. And this seemed to bear out in many observational cohorts going forward, deeming this term of the obesity paradox, where we would think that people who were obese would tend to have worse mortality, but this was not shown in these dialysis patients. Some of the criticisms of this are that increased BMI is associated with increased mortality in those who have inflammation, but this may not have been studied in these patients. Dialysis patients tend to have a shorter lifespan, so maybe they didn't develop the issues with obesity that they may have developed if they had lived longer. And a lot of these studies only looked about 2 years out. The Fleischman study only 1 year, whereas a lot of the studies that look at the mortality and morbidity of obesity look at 5 years or more. These patients might have a higher blood pressure or more stable hemodynamic status. The low BMI also might be a sequela of a comorbidity that causes them to have higher mortality rather than the actual cause. And there has been some evidence that adipose tissue sequesters uremic toxins as well. So the bottom line here for me was, I don't think that we should be recommending increased BMI just because of this paradox that was shown. Finally, we'll take a look at the data of whether obesity treatment may help slow progression of CKD or even reverse it. So our main weight reduction strategies, we have lifestyle interventions, we have weight loss medications, and we have surgical interventions. So with lifestyle modifications, unfortunately, they aren't the best at sustained weight loss. Some reports say only 20% of people achieve sustained weight loss. I think that may even be high. The idea being that the body is defending against fat loss by returning to a set point of a certain amount of fat after starvation. So the body is really working against people when they're trying to diet and exercise and losing weight. One study or one cohort at University of Cincinnati, there was a group of 52 patients in a weight loss clinic that were referred there pre-transplant who needed to lose weight. 0 of the 52 patients were able to achieve the sustained weight loss they needed to become candidates with these lifestyle interventions, which is pretty disconcerting. There have been several small studies, both prospective and randomized prospective studies on diet, exercise, lifestyle interventions. Most of them are really small, less than 100 patients, some of them even 10 patients. Typically in those studies, people lose about 2 to 7 kilograms. There may be some renoprotective effects. Some of them report lower GFR or reduced albuminuria or proteinuria, but I think that they're too small to really hang our hats on. What does have more efficacy are some of the anti-obesity medications, and there's a handful that are approved by the FDA. The first one here is orlistat. It's actually available over the counter. It's called Ally, and it inhibits fat absorption. But the biggest issue that people have with it is that it causes fecal incontinence in up to 16% of people. And it also causes fat-soluble vitamin deficiency and some reports of oxalate nephropathy. And this brought to mind the sugar-free gummy bears with fecal incontinence. If you want to laugh, check out the Amazon reviews of these gummy bears online. The next drug is phentermine, which has a lot of issues with causing hypertension, and it's also available in combination with topiramate or Topamax. Again, can't be used with uncontrolled hypertension, and the addition of Topamax has been associated with renal tubular acidosis and kidney stones. And both of these medications have not been studied in CKD, so probably not great options. There's also bupropion naltrexone combination. These can cause some GI effects, and they also are excreted primarily in the urine, so not recommended in advanced CKD. But what we do have is liraglutide on this list, which is a GLP-1 agonist. The main side effects are GI, nausea, vomiting, diarrhea, but it can be used in all stages of CKD with some dose reductions. This is a chart showing the average percentage of weight loss in many of those drugs with the addition of semaglutide there in the middle. So semaglutide was actually just FDA approved for weight loss in June, and it's under the brand name of Wegovy, but previously you may know it as Ozempic for treatment of diabetes. And it actually, in the large study, had an average of almost 15% of weight loss. So way above all the other medications here, including the liraglutide. And here we just have a summary of a couple of the randomized control trials of the GLP-1 agonists. So the big semaglutide SUSTAIN 6 trial in 2016, about 3,300 patients, some of whom had CKD or cardiovascular disease. And they looked at varying doses of semaglutide versus placebo. And as far as kidney outcomes go, it reduced the kidney composite outcome by 0.64%, which was largely driven by reduction in persistent macroalbuminuria. Then we have the liraglutide randomized control trial in 2018. This was even more patients, about 9,300, again, similar population, cardiovascular or CKD risk. And they looked at liraglutide versus placebo. And as far as the kidney outcome, again, reduced the risk for the composite outcome, mostly driven by new onset macroalbuminuria. So we have these randomized control trials of this class of medications, these two in particular, which have shown to have benefits for the kidney and seem to have the best weight loss in the case of semaglutide. These are the new American with Diabetes Act guidelines for treatment of diabetes. And I highlighted here on the right, the part of the algorithm with patients with heart failure or CKD. And we're all familiar with the SGLT2 inhibitors, which is preferable here. And just as a fact, SGLT2 inhibitors on average can cause about 0.8 kilograms of weight loss in CKD patients that were looked at, probably due to the diuretic effect. If you go further down the algorithm, if the SGLT2 inhibitor is not tolerated, or if it's contraindicated because the GFR is too low, then you can add the GLP-1 receptor agonist. And additionally, what I didn't realize before looking into this is that you can add the GLP-1 receptor agonist to the SGLT2 inhibitor. So you can get the additive effects of the weight loss on top of the beneficial effects we already know come with the SGLT2 inhibitors, and to some degree also with the GLP-1 agonists. And we saw that semaglutide has greater weight loss than liraglutide, so that one is probably preferred. Finally, we have metabolic surgery as an option. So we know that metabolic surgery has great effects on a lot of metabolic syndrome issues. One study of obese patients matched with a cohort that did not get surgery versus those who did seemed to be more efficacious at preventing the development of diabetes than standard care. Blood pressure tends to be greatly improved. Weight loss surgery was associated with nearly 7 times less need for blood pressure meds compared to medical therapy alone for weight loss. And there may even be some improvements in diabetic nephropathy once it's already developed. In this small cohort of 52 obese patients with diabetes and diabetic nephropathy that underwent surgery, at 5 years, they reported that 58% had resolution of their diabetic nephropathy. So who qualifies for metabolic surgery? Anyone with a BMI of greater than 40, a BMI of 35 to up to 40 with at least one of the following comorbidities: diabetes, hypertension, hyperlipidemia, non-alcoholic fatty liver disease, cardiovascular disease, sleep apnea, or cancer. I could not find that CKD was one of these comorbidities. And they must have failed non-surgical treatments for these comorbidities. The process by which a patient can become a candidate for metabolic surgery, though, is largely driven by the insurance companies, which might require patients going to support groups, losing a certain amount of weight prior to the surgery, things like that. So very briefly, I just wanted to go over some of the options that are available. They fall into two camps, restrictive and malabsorptive. The restrictive ones, the main ones that you'll hear about, are the gastric band or the lap band, or the gastric sleeve, also called sleeve gastrectomy. So with the gastric band, an adjustable band is placed around the upper portion of the stomach, and this restricts how much food can go through and causes a sensation of fullness. That band can also be adjusted by injecting saline into a pouch under the skin. And this has weight loss of up to about 47.5%. The gastric sleeve requires removal of the greater curvature of the stomach. So the stomach itself is much smaller, and this has been purported to have about 68% weight loss. Of the diversion options, there are multiple, but a couple of the main ones are the Roux-en-Y gastric bypass and the biliopancreatic diversion. So with the Roux-en-Y gastric bypass, it also requires a restrictive portion. They create a new stomach pouch, which is smaller, that is hooked up to the lower part of the small intestine. And that basically bypasses the small intestine so that less nutrients can be absorbed. And then with biliopancreatic diversion, again, a portion of the stomach is removed, and the stomach is connected to the ileum, as well as the pancreatic and bile secretions do not mix with the food until very distal, again, limiting absorption. And with these two options, Roux-en-Y has up to 62% of weight loss, and the biliopancreatic diversion has the highest at 70%. So there've been a handful of studies. Most of them are prospective observational. This one looked at renal function 12 months after bariatric surgery. So these were 233 obese patients. And at baseline, they had varying GFRs. About 26% were deemed hyperfiltration. About half had normal GFR. 17% had CKD stage 2, and only 2.5% had CKD stage 3. So this is just the baseline characteristics at the top here. You can see the mean GFR of each of these categories of initial GFR or CKD. And then at 1 year, you can see the changes in their GFR. So we can see that the hyperfiltrators, their GFR dropped, and in the other categories of normal GFR, CKD 2 and 3, all of their GFRs improved or increased. The problem with this study that is brought up in others is that they only looked 1 year out from surgery, and early on with these massive amounts of weight loss, you see a lot of muscle wasting. So whether this confounds the improvement in GFR, which is creatinine based, by loss of muscle mass alone, has been controversial in terms of what this is actually doing to the patient's GFR. So this group wanted to look at that by comparing to patients' weight loss and their CKD risk at year 1 and beyond. So these were about 1,800 people, most of whom had a Roux-en-Y and the rest had gastric banding. And they were looking at the change in CKD risk categories. So we are probably mostly familiar with this diagram. This is based on the GFR and the albuminuria categories. And they were looking at whether people changed categories after their bariatric surgery. The majority of the patients here had low risk. so CKD 2 or lower with less than 30 milligrams per gram of albuminuria. Then about 12% were in this mild risk or moderate risk here. Then even less, 34% were considered high risk, and only 1.4% were in the very high risk category. And they looked at these patients for 7 years. So this diagram breaks down the risk of progression to those higher stages or to a lower stage at different starting risk categories. So at the top here, we have the very lowest risk patients. And of course, they can't get better because they're in the lowest risk. But we see that many of them stayed the same. These are in the green bars. And a handful of them got worse, about 4 to 9% increasing as you got out to year 7. In the moderate risk category, these patients who can get better or worse, we see that a good number of them actually do improve. And the numbers here are 51% by year 2 have improved their risk category. And out to year 7, 35% are still improved from before they got their surgery. When we look at the high risk category, and this is a small group of people, only 27 who got surgery in this group, we see that some of them improve, about 58% of the group at year 2 and about 36% by year 7. And with worsening, about 8% worsened at year 2 compared to year 1 and 20% at year 7. And then we finally get to the very high risk category, who by definition can't get worse in category. Some of them do get better, about 30% at year 2 and about 36% at year 7. But about of the 12 patients who got surgery in this category, 5 of them did end up progressing to ESRD in the 7-year period. Then we have a handful of meta-analyses which look at various renal outcomes in lots of different bariatric surgery studies. And I will say that these are very heterogeneous in terms of their size, in terms of what procedures were done, how outcomes were measured, follow-up duration. So this has to be taken with a very large grain of salt. In this particular one, there were only a couple of studies that measured proteinuria. And this was proteinuria on a 24-hour sample before and after surgery, only in 159 patients in all of the studies that they looked at, and seems to favor getting better after surgery. This one looked at albumin creatinine ratio before and after surgery. And we've got after surgery on the left-hand side of this diagram. We seem to favor that it gets better after surgery, but when you look at the absolute reduction, it's only 12 milligrams reduction in albumin creatinine ratio post-surgery. This one stratified by GFR pre and post-surgery to see if it improved or if it got worse after surgery. So in the patients who had a GFR of less than 90 overall, this seemed to favor that there was a significant increase in GFR with surgery. When they looked at patients with a GFR between 90 and 120, there doesn't seem to be a very big difference here. And the composite is right on the line. And when they looked at the patients who were hyperfiltrators or GFR above 120, their GFR seemed to get lower or reduce hyperfiltration. And this technically met significance in this meta-analysis. Finally, we have one randomized control trial on the effect of gastric bypass versus the best medical treatment on chronic kidney disease in those with diabetes and obesity. So this was 100 patients, pretty small study, type 2 diabetes with a BMI of 30 to 35, and they had stage 1 to 3 CKD with a urine albumin creatinine ratio of greater than 30 milligrams per gram. Though I will say the average in both groups was 72 or 73 milligrams per gram. They randomized them either to the best medical treatment or to get a Roux-en-Y gastric bypass. And the primary outcome was looking at remission of albuminuria, which was categorized as less than 30 milligrams per gram. Secondary outcomes looked at things like CKD remission rates, absolute change in urine albumin creatinine ratio, and various metabolic parameters. So here in figure 2A, we can see at 12 months and at 24 months, the change in, or the remission percentage of albuminuria, so less than 30 milligrams per gram. And they do overlap at 12 months between best medical therapy and the gastric bypass surgery. But when you get out to 2 years, there is a statistical significant difference in between best medical therapy and the Roux-en-Y gastric bypass. But if you look at the absolute numbers, these patients who had the gastric bypass, by the end, they had a urine albumin creatinine ratio of 10 milligrams per gram, whereas the best medical treatment had 24 milligrams per gram. So though this was statistically different, I wonder how clinically different it is, especially wondering about the error margin of the test. And there is one future randomized control trial that's currently enrolling. Again, fairly similar, obese patients with diabetic kidney disease who will either get gastric bypass or standard medical therapy, which will include SGLT2 inhibitors, as well as ACEs or ARBs. And for their diabetes, they will get GLP-1 agonists in addition to other medications being allowed. And they are looking at efficacy and safety of the surgery versus treatment and progression of diabetic kidney disease. So we'll have to stay tuned for this one. It won't be complete till 2024. So we should also talk a little bit about the risks of metabolic surgery. One being micronutrient deficiencies, iron, vitamin D, zinc, copper, protein malnutrition as well. Some have been associated with hyperoxaluria and calcium oxalate stones, but this is highest in biliopancreatic diversion, more so than the gastric bypass, but no increased risk in sleeve gastrectomy. There have been higher complication rates seen in CKD patients when you adjust for their diabetes and hypertension, but it did remain less than 10% of complication rates. Here's a proposed algorithm for what to do when you're in the clinic and you see a patient. I think the most important one being on this right-hand side, the non-obese patients. So those with a BMI less than 30 or less than 27.5 for Asian patients. But I also added the waist circumference because patients we know with a normal BMI can have increased risks with a higher waist circumference. So these cutoffs again are here, 102 centimeters for men or 88 for women, and lower in Asian populations, and recommending lifestyle-based therapies and anti-obesity medications being considered, even at these lower BMIs, but with increased abdominal adiposity. So I went and contacted the different hospitals to see what resources were available. At UC Health, we have the wellness clinic. It has a variety of nutritional services, behavioral health, medication assisted treatments. And then we have the surgical weight loss center. There's various locations around Colorado. I was able to get a hold of one of the centers. They said that they don't have a BMI cutoff per se, but that the patient's insurance will dictate whether they will have a BMI too high to undergo surgery and may need to lose weight before they can get surgery. At the VA, we have the MOVE program, which has resources for weight loss, exercise, support groups. And it sounds like for here, the bariatric surgery would be a choice referral where the hospital contracts with other centers to do the surgeries. And then at Denver Health, we have the Healthy Lifestyles Clinic. And there's no way to put in a referral for this, but patients can get referred through their PCP as these clinics are associated with their primary care clinics. And there's also a bariatric surgery program at Denver Health, but their BMI cutoff is 60. So if a patient has a BMI higher than that, they will need to lose weight before they can get the surgery. So to come back to the case that we started with, this patient was referred to the bariatric program at Denver Health, but unfortunately, because her BMI was more than 60, she was denied for surgery and needs to lose about 50 pounds. She was referred to go back to the Healthy Lifestyles Clinic to help her lose that weight, but she hasn't yet had an appointment with them. And I think that we should consider a GLP-1 receptor agonist, especially knowing the great amount of weight loss that has been seen with semaglutide. So in conclusion, increased waist circumference should be an indication for weight loss, even if the BMI is normal. We should consider GLP-1 agonists for weight loss adjunct in our CKD patients, and we can add these to the SGLT2 inhibitors that they may already be on. And obesity is in a patient who's otherwise eligible for transplant but can't get one because of their BMI is the most important modifiable factor that can influence their survival. So we should be especially aggressive about helping these patients. Here are my references and wanted to open up for questions or comments.
Thank you, Natalie. That was fantastic. Very nice review. Quick, maybe not a question, more of a comment. I understand the transplant center has some type of link with the wellness center where they are referring some of their obese patients to the wellness centers, getting through a program, try to get some weight reduction before listing them for transplant. In your interactions with the transplant center, have you heard of this, or do you know how this is progressing, if it's ongoing?
Yeah, I've heard of patients going to there. I haven't followed them or heard exactly the experiences, but I do know that there's a connection. Maybe someone else can comment better than I can.
Hey, this is James. You guys hear me?
Very good, James. Yeah.
Yeah, this is a program that was fairly recently started up by Kendra Konzen, one of the surgeons. And it's pretty early in its development, but she's had a handful of patients that she's been able to get involved in the program. So I think it's a great initiative. Yet to see how successful it is in outcomes.
I have a quick comment. Natalie, did you, I didn't see it, did you measure the anti-PLA2 antibodies in your patient?
Yes, they were normal.
Okay. Because I've had a couple, 2 or 3 patients with morbid obesity who come up with positive tests, and we've been able to treat them for their membranous. The Wegovy is a really great drug. I recommend that you give that to your patient.
Natalie, there's just a comment here from Dave Saxon, Dr. Saxon, who says that Tom Jensen is the endocrine person to go for weight loss and transplant. So this is obviously important for everyone. Natalie, another question going back to the adverse events, and I guess obviously there have been randomized controlled trials, and you mentioned obviously kidney stones. What were the main adverse events on that JAMA surgery paper? Did they report a higher prevalence of kidney stones?
I don't recall. I'd have to look back.
Okay. My sense is that it's obviously, a concern, but in this randomized controlled trials, it doesn't appear to be as much reported as we would expect.
Mm-hmm. Yeah, it seemed like it was felt to be more of an association in the general reading I was doing.
Right. Any other questions for Natalie?
That was great, Natalie. That was a really good job.
Thank you.
Thanks, Natalie. That was fantastic. Thanks for the presentation and looking forward to the day.
Thank you very much.
Thank you.